Dr. Jacob Sexton. I'm one of the non-operative sports medicine physicians. That's our Frisco satellite clinic over at Kirkendall Stadium. We're there usually Monday through Friday. My clinical hour is a little bit different right now. It's from 9:30 a.m. and my last patient's at 5:30 p.m. for the most part. But if you have any emergencies and those type of things, like Forrest says, it's easier just to reach out to him for the most part if you have something urgently that you feel like needs to be seen quickly. And usually we do a good job of getting you on the schedule, okay? So if you have any question, concerns, reach out to Forrest or to myself, and then we'll try to get your athletes in as soon as we can, okay? So medical review day, we were asking, what do we cover? What do we want to talk about? And so we kind of pulled it out. And one of the things I noticed that was increasing in my clinic, and one of the things some of the athletic trainers were talking about was, where to go? There we go, talking about spondylolysis and back pain, because we've been noticing kind of an uptrend, particularly this past spring. I've been noticing a lot of those, particularly with my track, football, baseball, and volleyball players. So my objective today is going to review that lumbar spinal anatomy. We're going to discuss some developmental biomechanical risk factors associated with development of spondylolysis and stress reactions. We're going to explore some preventative and rehabilitative measures for the athletes with lumbar spondylolysis. And then I'm going to briefly talk about some hip apophysitis and avulsion injuries, show you some classic injury patterns that you see with it, and kind of identify some of those at-risk athletes. So always got to talk about anatomy because that's important. You got to understand your anatomy before you can understand how to treat your athletes. So of course, the spinal column separated into 7 cervical vertebrae, your 12 thoracic vertebrae, your 5 lumbar vertebrae, and then transition to the lumbosacral junction where you have fused vertebrae at the sacrum and the coccyx itself. Importantly, as you go from the top down, when you go from here, as you go down to each level, you see that the vertebral bodies increase in size, increase in diameter and weight in order to increase those increased weight-bearing loads as they go down the spine. And what you also see is the vertebral foramen narrows as it goes down, as the neurons have left the spinal cord, so you don't have as many nerve roots exiting at that point in time. And on the right, we got to understand the importance of that lumbosacral junction that attaches that axial skeleton to the appendicular skeleton, and any deficiencies with the hip and pelvis and knees and ankles can result into injuries into the central core skeleton, particularly the lumbar spine in our young athletes. So continuing on, we got to think about the other parts of the spinal anatomy, make things a little bit more difficult when we're evaluating treating these patients. Over 29 pair of muscles start from the cervical spine all the way down to the lumbar spine. That's not including your pelvic rotators that we always talk about and those type things. And if there's any disinhibition, if there's any chronic injury and those muscles are not coordinating properly, they're not able to transfer those forces through the lumbar spine or from the pelvis through the lumbar spine to get those sport-specific maneuvers that the athlete needs, because the spine not only takes compression forces, it has shear forces, rotational forces, and all those factors together can result in injury. So it's important from a dynamic standpoint to have appropriate muscular control and balance. The bottom left image is kind of one of my favorite ones, the multifidus muscle, the one we always kind of forget and always kind of neglect, but it's so important for subsegmental movement of each vertebrae. So if you're not able to activate that properly, that's when you see those guys that have very poor thoracic motion, very poor postural control when you're evaluating them. And then of course, our classic QL, quadratus lumborum, that you see injured a lot of times, sometimes in the weight room. And then finally, the top right one, we got to think about the muscular anatomy, the bony anatomy, but you got to think about the soft tissue structures as well. Those ligamentous structures that are holding the spinous process together, and those intraspinous ligaments that hold those spinous processes together. That's when you get those kids that have that very pinpoint spinous pain, kind of those kissing injuries that you get sometimes. They can actually have injuries to those soft tissue ligaments, and those can give those mimicking symptoms like that electric shooting pain and those kind of diffuse pain. So you got to think about more outside than just your bony anatomy or muscular anatomy. So continuing on, like I said, as we go through our anatomy, we need to think about the pelvis itself. So the sacroiliac joint's another problem that usually we discuss. Is kind of composed of 2 separate joints. There's a true synovial joint that's further down, or more caudal, while the more cephalad is more of a true ligamentous attachment. So you got to understand the difference between those two. Then on the top right image, we see this very large thoracolumbar fascia. And so that connects your major trapezius, your middle and your lower trapezius, your gluteus maximus, your latissimus dorsi. So your major muscle groups all combine and share the similar fascial plane. So if your athletes don't have the appropriate range of motion, that's going to result in restriction of not only lumbar spine, but some of the axial appendicular skeleton stuff, such as your shoulders with latissimus dorsi and your pelvis with the gluteus maximus. And then again, we always need to think about the importance of our external rotators, about going all the way from the piriformis down to the quadratus femoris. They should be strong and be able to activate so you have appropriate pelvic alignment when you're trying to do those multi-directional sport-related activities. The bottom left one I like to talk about is, why are our hip flexors so tight, and those other type things. I think we always kind of forget that the iliopsoas muscle is composed of the psoas muscle and the iliacus itself, with the psoas muscle actually originating on the lumbar spinous processes. It then crosses the inguinal ligament and then attaches into the femur. So if you have any tightness along that iliopsoas muscle, you can see how that can result and cause problems with associated back pain. Okay. So I think it's very important to understand this anatomy and the relationship between the lumbar spine and the hip and pelvis structures. Then again, we got to think about the other muscles associated with it, your hip flexors, your tensor fasciae lata, your quadriceps muscles, all of your hip adductors as well. We got to think about these muscles in the hip, pelvis, and lumbar spine being multiple joint muscles, so they're predisposed to particular injuries, particularly the hamstring muscles. Then finally, of course, we always got to talk the important stuff. You got your dermatomes. You should always be able to know and identify those dermatomes, their associated myotomes, and the associated reflexes with those. I'm not going to go through each one of those today, but those are something you should always know when evaluating your athlete when they ever complain of any kind of lumbar spine or any associated back pain. So how often do we notice back pain in athletes? These two studies, one in 2017, one in 2021, was kind of just a meta-analysis, kind of get an idea of how often we're seeing back pain in these youth and adolescent athletes. What I do notice repeatedly go to these studies is point prevalence is usually how they look at it. And even in a 1 year or 3 month period, about anywhere from 14 to 64% of your athletes in the collegiate world is usually around 15 to 30% from the studies are going to report some kind of back pain during their professional, amateur, or high school career. Usually in the young athletes, the most common diagnosis associated are spondylolysis and spondylolisthesis, your disc degeneration injuries, and then of course your soft tissue injuries such as strains and sprains. While the other meta-analysis identified key risk factors, and we have all heard these before, your higher training volumes, your longer participation in sports, the longer you do it, the more likely you develop those injuries, prior history of back pain, family history, and of course obesity and increased body mass can all help predispose you to developing low back pain. So spondylolysis, what we're here for today, let's talk about it. So what is it? It is a defect or stress fracture of the pars articularis at the vertebral arch. So we can lower that down a little bit. What I'm looking for here is I'm looking for this bridge, this osseous structure that bridges the posterior vertebral elements to the anterior vertebral elements. And so what happens is there's a failure of this posterior vertebral arch, which results in a stress reaction development of low back pain. This bottom image here does a better job of kind of describing it, that pars articularis, and you can see how one facet from one vertebrae articulates with the facet of the lower vertebrae. So if you develop a stress reaction at this point or develop a stress fracture at this point, this joint or this facet area is no longer doing its proper function. It's not going to be able to take the compressive loads. It's not going to be able to take the axial loads, those shear loads. The forces are going to be dissipated to the contralateral side of the spine instead. Most commonly, this occurs at L4, L5, L5, S1, and again, it's secondary to repetitive, rotational, axial, and mechanical forces. Very rarely does this present with true neurological findings. What you see more is this kind of vague, hard to identify, hard to describe pain, and we're going to discuss some risk factors a little bit later on that can help kind of raise and lower your suspicion for these injuries. It can be unilateral, bilateral, and that's going to be sport dependent. So with my baseball guys, pitchers is always, every time it's always unilateral, and it's usually on the contralateral side of their dominant arm, because that's when they're in the windup and loading up and getting to that extension before they get to the cocking phase. They're asymmetrically loading that lumbar spine. Same thing with my volleyball players. They're repetitive serves. You're loading asymmetrically and loading one part of the spine, as opposed to your track and your football athletes where you're doing things that are loading both sides. So you have a higher chance of getting the bilateral spondylolysis in those situations. So this study was done actually in 2021 and 2022. And what they did was they took adolescent athletes from age 13 to 18. Anybody that came with back pain, they went ahead and got an MRI because they wanted to see, could they identify early findings of stress reactions or spondylolysis before the end stage occurs. Because if you see the Scotty dog, which we're going to show you later, you've already missed the ship. It's already sailed off because you want to catch it early before it turns chronic. So each one of these kids, they took 157, and that the key takeaways they could identify is the big risk factors were low back pain greater than 4 weeks. You have an odds ratio of 3.3, which 3.1 basically means they are 3 times more likely to have an underlying stress reaction as compared to somebody else. Low back pain with running, that increases it to about 3 times. Low back pain starting with a specific side where it's right on that right side, they can pinpoint it and identify it very localized. That gets my suspicion. and low back pain with tenderness at the spinous process. Those are the big risk factors they identified that has significance that can help guide you into more of a stress reaction type presentation as opposed to your kind of soft tissue injury, strain, sprains. The bottom right image or the middle image right here kind of shows one of the images the MRI looks like. So you can see this increased signal here at the pars and articularis on this side, showing an underlying stress reaction without a fracture, while this sagittal view here again shows increased signal on this vertebrae as compared to this vertebrae. So that's identified of underlying bony injury, probably a precursor to spondylolysis, but I treat these all along the same line. There's inflammation or stress in the bone, that's a precursor to spondylolysis, so they're all treated on the spectrum the same to me. Okay, and then this bottom, oops, let me go back real quick. This bottom right picture just wants to show the importance of why we have to let these things treat and let these things heal appropriately. So this bottom left on A right here shows a unilateral lesion, and you can see the forces are still somewhat dissipated okay when there's a single fracture or when there's a single break. But when you ended up keep participating, you ended up developing on both sides. Now all these rotational forces are going to move to the anterior aspect of the vertebrae. And that's when you're going to get development of stuff like spondylolisthesis. You're going to actually develop focal neurological findings and those type things because there's increased risk of shifting of the vertebrae, increased risk of pinching on a nerve root as it exits the spine. So what are the risk factors that we need to worry about, things that we can think of? So any period of rapid physiological development, so all of our high school, all of our middle school athletes, so every one of them we're working with, are predisposed to underlying stress injuries. Why is that? They have rapid bone turnover. They're metabolically active. They're trying to get taller. So in order to get taller and let the bones grow and ossify, they have to break down, be reabsorbed, and then subsequently put down more bone. That's going to have to go through process, and that's when the spine is the weakest. In particular, is the posterior or the backwards vertebral elements, your pedicles, your lamina, and those type things, where there's not as much bony structure as opposed to the front anterior part of the vertebrae, the vertebral bodies, where they can take a little bit more stress and a little bit more loads. The other thing is they got rapid growth, rapid turnover, they're getting taller, but the muscles, the ligaments, the tendons, the soft tissue structures, they don't really coordinate that well together. So that's when you start getting soft tissue structures and constrictures, and that'll decrease your passive and active range of motion. And we all know with decreased associated range of motion, that's going to increase your risk for underlying injury. And then again, all these athletes, they're not completely mature from a proprioceptive and from a neuromuscular coordination standpoint. We've all watched the 7th graders when they go out there and play their first basketball game. And then we watch them 2 years later when they get 9th grade and that coordination changes. So we got to make sure that these athletes had the core pelvic neuromuscular stability to do these activities that we're asking them to do on a daily basis. So when I'm evaluating my athletes, what are the things I'm looking for? The first thing I always do when I'm looking at them is, and I finish doing their back exam, I want to see overall what their core and pelvic stability is, because to me, that's probably the most important thing I want to identify. So I always go through a Trendelenburg, because if they're passively having positive Trendelenburg and their pelvis is tilting, standing on one leg, that automatically lets me know that their hip abductors are weak. If their hip abductors are weak, I guarantee probably their hamstrings are weak. And then it's going to go straight up through every one of them or the whole part of the chain. The next thing I want to do is I want to see how they squat, particularly my young females. I want to see, do they immediately go into that valgus knock knee position as soon as they go? Or are they going to be more in a neutral position when they squat down? Or is it one of those, as soon as they squat down, their knees go straight forward and they're about falling over themselves? Or is it one where they're squatting, the first movement is they take the lumbar spine and they're bending over right at the trunk, and you're like, oh gosh, please don't be squatting 400 pounds in the weight room. The other thing we do is I have them do a single leg squat. Everybody's going to fail my single leg squats, but I do it just to see what kind of control and what they do. Is the athlete able to do the single leg squat, or is their first movement going to be pelvic rotation, valgus position to get that center of gravity, center of balance? It just kind of gives me an idea at the level of what kind of development and coordination they had, because every one of them, no one's going to be perfect at that part at this age. I just want to see where they're at. And then sometimes I actually put them in plank position. So I want to see, can you even hold a plank for 10 seconds? If they already 10 seconds, they're already shaking, they're already vibrating. Okay, there's no core strength there. And then sometimes I even lay them down. I'll see, can you do a pelvic bridge? Can you do a pelvic tilt? I want to see you move your pelvis, rock your pelvis. A lot of times they don't even have that cognition and that ability to do that. And if they're not able to do those things, it's going to predispose them for injury. So again, this goes to this: soft tissue, range of motion, posture. Always look at their posture first as well. In society today, we spend most of our time sitting in a chair. Since you're sitting in a chair most days, your hip flexors are always activated. They're always contracted. So they're going to be tight. That's why everybody's tight nowadays. So what's that going to do? That's going to put your pelvis forward, right? So then that's going to take your hamstrings. Your hamstrings are always going to be activated and lengthened. They're going to be weaker, not as wanting to activate as much. So then you kind of develop a little bit of excessive lumbar lordotic curve. And where does all those stresses go when you're doing those activities? Going to go right through that lumbar spine. Then it's also important to identify any risk factors in the hip and pelvis and making sure their hip rotation is good, particularly that internal and external rotation. So diagnostic imaging. So we used to do x-rays. We learned now that if you see the Scotty dog, which, oh, it went too far. Let me go back. Oh, it doesn't have it. I drew a picture of the Scotty dog, but it's not showing up. So if you want to look through here, you kind of see this is the dog's face coming up around. There's his tail. There's a leg, and that makes the dog. If you see the Scotty dog and the defect there, that means it's already like stage 3, stage 4. The ship's already sailed. I don't want to see the Scotty dog on my exam. I want to see a normal set of x-rays, okay? So usually if I'm going to think of advanced imaging, I think of MRI, but I still want to talk about CT, and why don't we use CT as often as we used to? CT does a good job identifying the fracture, but it can't tell you if it's an old fracture or a new fracture. It just says there's a fracture, okay? The other thing it can't tell you is there associated disc injury? Is there a vertebral body desiccation? Is there nerve root impingement? So the MRI gives me more soft tissue information that a CT does. And then finally, I'm not a fan of irradiating young athletes. I'd rather use something that doesn't provide a radiation dose if I can avoid it. Now, sometimes we used to use this on the far right. This is single photon emission CT or SPECT CT. It's basically a CT scan, but what they do at the same time is they inject a radionucleotide into the person's body. And where there's areas of increased metabolic demand, such as a stress fracture or a fracture, those radionucleotides will preferentially uptake in those particular areas. So as you can see on this axial image on the far right, there's increased uptake there where you can see a fracture line through the pars and articularis. So if I saw that, that would let me know this is an active fracture with active healing, active inflammation occurring. And then as you can see on this other side, not as much uptake here. Problem is in young athletes, they're growing, they're developing, so everything's metabolically active. So this study doesn't do as good job in younger athletes, it's more for older athletes. So now we've transitioned to more MRIs for diagnosis and management of these. So these are actually 2 of my athletes I've had this year recently. So this is an axial cut right here. This is L4, if I remember correctly. As you can see here, you have a radio, you have signal here on the pars and articularis, and you can see the difference on the side. There's no signal here. On this one, you can see a fracture line coming right through there. So this will probably be a stage 3, close to stage 4 level stress reaction. This is the same image on the, for a sagittal view. You can see here the signal in these areas relatively normal, but as you go through here, you have increased signal there. You can actually see that radiolucent line. So this is another image. I just want to show you the difference between the two. So this is the same exact patient. The axial images, this is L4 on the right. This is L5 on the left. As you can see here on the normal side, you have normal gray appearance of the bone and the other osseous structures. You have your spinal cord with its nerve root sitting right here. And then when you go to this other side, you have this normal gray appearing vertebral body. But as soon as you get into the posterior vertebral elements, you just have all this increased signal through here, demonstrating bilateral stress reactions or early spondylolysis. So management, what do we want to talk about? So what's the management? How long do we hold them out? There's your answer. We don't know. Okay. We've been talking about this for years and years and years, and I read about this all the time, and I still can't find any definitive answer. Okay. So I've been coming up slowly after working with these a long time on how I manage these. I feel like we've had relative good success. So this is kind of how we go from it. So timing, how long do I hold them out? That's everybody's question, right? How long you gonna hold my kid out from playing sports? Well, I always like to compare my high school athletes to my professional athletes, right? Because the professional athletes have every resource available in the world, okay? High school athletes should not have all these resources. So this is the HITS database from Major League Baseball. And if you don't know what the HITS database is, it is a injury reporting system for all minor league and major league baseball players. Every injury has to be recorded, has to be documented. So they went through this and they found every incidence of back pain. And then they went down and found all the incidents of specifically spondylolysis. So 28% incidence in the MLB, average return to play, 51 days. Okay, that's their average. Okay, so if a professional athlete who has all of the resources available to them cannot get back for 51 days, and that's the average, how am I going to put somebody who has half those resources there before that, who's metabolically active, who's trying to grow and develop, who needs soft tissue recovery, who's trying to grow and be a normal athlete? Here's the thing about, if you hold them out properly, they did a sub-analysis of this and said, okay, what's their ERA? What's their batting average? What's their slugging percentage, fielding percentage after doing all these things? 98% returned to their previous level of play without impact on their player performance scores. So they came back to the same, if not better than they were before they got hurt. So if you treat it right, it can get better. Just time, and nobody likes that. So physical therapy is what we do. So if you come into my clinic and you're not concerned about a stress reaction, first week, phase 1, weeks 1 through 4, we're shutting you down. You're done. We're not going to do much with you. My goal in those days is get pain resolution. I avoid extension-based activities because I'm trying not to load those posterior vertebral elements. We want to work on initiation of deep abdominal core, so multifidus activation, quadratus lumborum. We want to start working on all those muscles, transverse abdominis. We want to do non-impact activities. So I'll let them, sorry, let me change that. We do non-impact activities as tolerated. If they can get in the pool and there's no pain in the pool, I'm okay with that. That works on range of motion. It's weightless. It's not putting a lot of stress through the back. If they want to get on a bicycle, it doesn't bother them, that's fine. But what we got to take out is we got to take axial loading. We got to take repetitive closed chain impacts out. We got to take running out. We got to take all those forces and let them calm down to let the bone heal like we do with every other stress fracture. So then phase 2, usually around week 5 is when this happens. That's when I start formal physical therapy with them. Okay. I start incorporating extension-based exercises back in. We start trying to initiate plyometrics in a pain-free motion, but during those times, if they have any pain, I just back them off a little bit, and then we kind of progress them as we tolerate. We look again at that core and pelvic stability, and then I start allowing them to do more pain-free activities because I know they're not going to want to stop stuff for over almost 2 months. So I'm like, you go out and dribble. There's no pain with dribbling. Go dribbling. Go bicycle. Go jog if there's no pain. And we'll start progressing you up as we tolerate. Again, there's not going to be any weightlifting going on. There's not going to be excessive strength and conditioning go on. If your sport allows you to, I might let you do some sport-specific drills, but I'm not going to let you go and we don't do them anymore, the Oklahoma drill, any of those type things. So then we get you to phase 3, and phase 3 is kind of the end. That's when I'm getting you back into sport-specific exercises. I want to initiate your sport-specific position drills, return your strength and conditioning workouts. And then at that time, that's when we start transitioning them to kind of our sports-based performance is what I would like to kind of identify any other additional risk factors that I might not can treat in my clinic and we might not can meet in physical therapy. So bracing, do we brace? So luckily they did a study for us. No difference in clinical outcomes with early bracing. The pros of it does make your pain a little bit better, does improve your posture a little bit better, but it's kind of reserved for refractory cases. Why? Because we're dealing with teenagers. They're not going to wear it. Every time I've tried to order it, all I have to do is threaten them that they're going to have to wear the TLSO, and then all of a sudden physical therapy starts getting a lot better and they start working a lot better. They don't wear it when they are recommended to do it. The other problem is with prolonged bracing, you get core muscular inhibition. So as soon as I get them out of the brace because their pain's better, now I'm spending the next part of physical therapy trying to reactivate the atrophy, the disinhibition, and all the coordination loss that occurs from the bracing. And then, of course, range of motion restrictions and interference with daily life. So repeat imaging is always the next question that I get. So luckily, this guy did a lot of lectures back then, a lot of studies on spondies for me. Only 28% of spondylitic lesions demonstrated radiographic evidence of osseous remodeling. So it's one of those things that the parents ask me if I'm going to get a repeat MRI. I tell them, if it still shows a stress reaction there, what do you want me to do with it? Because now I have to treat it, right? If it's still there. So if the kid's pain-free, if the kid has full range of motion, if the kid's progressing back into his sports, we just say, okay, we're going to assume it's healing and not get that information, because it's probably not going to show evidence of a large amount of healing if you get those repeat images. So I hold my repeat imaging for a few reasons. If there's any development, any focal neurological findings, I did have one a while back, came in, had an MRI with bilateral stress reactions at the spondies, then developed kind of some L5 radiculopathy about a month later, had a repeat MRI, showed there was development of a little bit of nerve root impingement. Okay, that lets me know because I'm looking for alternative diagnosis in that situation, because I had an alternative diagnosis that I was concerned about at that time. I do refractory pain despite conservative treatment sometimes, just to see if I'm missing something or something that might not have been identified on the original MRI. And or in history suggest development of Burkitt-Aquino syndrome, so saddle anesthesia, difficulty with urination, defecation, or your associated generalized weakness. So most importantly is, in my opinion, is probably nutrition and recovery for these, because it should be a focal point of every adolescent training regimen. This is from 2016. Luckily, we have Ms. Gabby here today. She's going to give a lot more information on this for us. But males, adolescent age, that's 2,800 calories a day. And that's on average before incorporating any of their physical activity, any of their weight training, or any of that other stuff that we expect these athletes to do. Females, 2,200. And again, doesn't take into consideration the nutritional needs for physical activity and hypertrophy. So then you got to have the appropriate education, because why is it important? Because we all know our athletes are doing extra stuff nowadays, right? They don't just come and play for high school. They got the private coach training sessions. They have their pitching coach, their hitting coach, their fielding coach, their glove making coach, whatever they want to make. I don't know. They have multiple daily practice sessions. You usually see this with gym and swim. So they're doing this intense training. They're doing 3-4 hours a day. And then you ask them about their diet, and they're like, I skipped breakfast. I might have had a snack for that. I think I had a sandwich for lunch and some rice. And I'm like, well, how are you going to recover? How are you going to get better with that? Again, strength and conditioning. You got to be able to get those soft tissue recovery. Not only that, we got to think about the agility, speed, and movement we do now. We don't just go to the weight room and do those things anymore. We're doing all these collegiate level activities with these guys. School versus club. And, I'm going to go play my club the night before, and then I'll come out the next day and play for my high school in a soccer match. And then your showcases or your guest appearances, all those things you got to think about in regards to nutrition and what these guys are doing outside. So how I think about it is youth athlete nutrition. You got to think about the soft tissue recovery as one component of it, because you got to recover after exercise. They then got to have the caloric intake and needs for your sport specific hypertrophy. You also need their basic metabolic needs, so their heart pumps blood and those other type things. And then again, we got to think about these athletes undergoing physiologic development. I think that's the one thing that's different that we're missing right now in the high school setting, is we're trying to train these kids like collegiate athletes, but they're not mature yet. They're not skeletally mature yet. And so if we're going to treat them like collegiate athletes, then this has to be a component of your training regimen at every school, because you're not just trying to get them bigger like you do when your senior comes back from his freshman year at college and he's put on 50 pounds. Yeah, he's done growing. He's done developing at this time. You got to get the nutrition needs, not only for them to soft tissue recover, then you got to make sure they grow normally and hit what they're supposed to. Then you might get to your hypertrophy. So you got to do more at the high school setting to get those nutritional needs. So the reason we treat this, because we don't want this to happen, right? So this is spondylolisthesis. This is displacement of spinal vertebrae, typically on top of one another, typically anteriorly. This happens when you have a bilateral spondylolysis that is not treated, and it's failure of those two, and they just slips forward. Again, focal neurological findings are relatively rare, but they're more common as compared to just your spondylolysis. Initial treatment, again, is conservative. However, you do have to have surgery if there's progressive slippage, any focal neurological developments, of course, refractory pain, or failure of conservative treatment. And then there is a technique called the buck fusion technique. You get 88 painless non-union, 82% return to sport, but I will tell you, I do not want to have back surgery. So this is kind of the classification for spondylolisthesis. Typically for us, we're only going to see the type 1, and then we're going to see the type 2A. The type 2A is the actual break or fracture of the pars and articularis, and that's the ones we're going to see from stress reaction from overuse and then subsequent slippage. So preventative strategies, soft tissue, joint range of motion. Do you think about doing some kind of functional movement screen with your athletes? Can they get into a squat position and actually get in a squat position? Is the first thing you see their heels are lifting off the ground. So it lets me know they don't have any dorsiflexion. They don't have any true hip flexion or any of those other type things. Are they undergoing proper dynamic warm-ups? Can you do yoga to help with those soft tissue restrictions? Postural correction, performance improvement. You got to focus on the core and pelvic strengthening, identifying, correcting improper lifting techniques, sport-specific movement pattern education, incorporation of plyometric, proprioceptive, single leg, core stability, landing exercises. Rest, avoid sport specialization. Good luck. Cross-training and off-season activities. That's something that we could work with, and I think that's kind of particularly, and I see it most commonly in our cross-country situation where, hey, man, we're in off-season. You don't have to run, land, train every day. Go in the pool, get on the bicycle. You still get your cardio and those type things in to help take some of that impact and stress off the lumbar spine. Recovery training sessions, soft tissue recovery modalities, and then nutrition. You might need to do weigh-ins with your athletes. Should they be putting on a little bit more weight when you're expecting? Annual nutrition education lectures with the athletes, self-reported calorie intake logs, provide, and have the schools provide post-workout, post-practice meals, because some of those kids are going to eat. Try to give them something. And then now we're going to switch over to hip apophysitis real quick, and then we'll be done. Hip avulsions. So big difference. The question I get from parents is, well, what's the difference between the growth plate fracture and the fracture you're talking about? We always get concerned about the growth plate fractures. Well, an apophysis is a normal secondary ossification center located on the non-weight bearing part of the bone. So if you look at the top right, the hip has a bunch of them. So you have the iliac crest for your attachment of your abdominal muscles. You have your ASIS for your sartorius, the AIS for your rectus femoris, greater trochanter for your hip abductors, your ischium for your hamstrings, and then the lesser trochanter for the iliopsoas, and then your adductors at the pubis symphysis. So that's more, they do not contribute to longitudinal growth. They are just growth plate centers to allow for attachment as the muscles and tendons develop. While as opposed to the epiphysis, which is the one we classically describe, which is the actual epiphysis being above here, the physis sitting through here, metaphysis sitting here. These bones on long weight bearing and long bones actually contribute to longitudinal growth, but do not provide attachment for tendons and muscles. So apophysitis. I was gonna say, is that the Texas Pledge of Allegiance that I'm hearing there? So apophysitis. Apophyseal stress injury is actually more of a stress injury, as there's no true inflammatory mediated factor. So it's more so just a stress reaction there. Most common in second decade of life. Why is that? They're now going through puberty. Their muscles are now begun to go in hypertrophy. They're strong. They're now getting stronger, but the bones are weaker at that time. That's the weak point in the chain. It's easier for them to get inflammation, stress at those bony sites because there's a cartilage bridge holding it there, easier to avulse. It's usually most common in those who either start a new sport. I see this commonly with my 13, 14-year-olds that start track for the first time and then try to do hurdles. And then the other ones are increase in intensity of the training. So they're not accustomed to that and they increase those volumes. They're also sport dependent. So typically the lower extremity ones are seen with repetitive microtrauma from rapid concentric, eccentric contractions. So your hurdlers, your sprinters, while the upper extremity ones, your little league elbow, your little league shoulder, all those type things are more from your upper extremity from those stress reactions. As opposed to true stress reactions, which is an early form of osseous stress injury, and it's a part of the spectrum of stress fracture. And they've actually attempted to try to grade these on MRI with periosteal edema all the way down to fracture lines being present at grade 4. So usually you're not really seeing fracture lines until it's later on when you're getting plain films and those type things. So let's go through a few of these and what you see. So pubic apophysitis or osteitis pubis, all those other type things. These might be hard to see because of the way the images are showing up on the screen. But if you look at the left side of this pubis right here, the cortex is smooth and regular right there. When you go to the other side and look at this right side of the pubis, it's irregular. There's a little bit of increased signal, so it's sclerotic. Almost looks like, to me, it's like chewed up a little bit. And so the typical presentation with these athletes, this is going to be your hip adductors, your groin injuries. It's been going on for a couple of weeks. It's now starting to progress. Instead of being kind of the inner part of the thigh, it's now starting to progress, and they're trying to, sometimes they'll complain of like even testicle pain if it's males, and they'll have, or females will have difficulty kind of complaining around the inguinal ligament area and those type things. It's right at that bony attachment. If you start seeing that, that's when you got to start considering slowing this athlete down, because this is a precursor to development of potential sports hernia. This is one of the early findings that you can get, because if you keep progressing through this, those adductors continue to get weak. That fibrocartilage that connects the hip adductors to your abdominal muscles share a common aponeuroses. So if you keep stressing through that, it'll eventually injure that aponeuroses, and then you're going to get a true development of sports hernia. And then you can turn something that might have been simple to much more difficult situation to treat. This is your ASIS avulsion. This is, I see this in my sprinters. This is where the sprinters come from. Oops. Actually, let me go back. Man, this thing's going wild. ASIS, kind of iliac crest avulsion right here. You can see on the right side of the image that apophysis is nice and smooth all the way through here, while you get on this left iliac crest and you have that defect right there coming down along the iliac crest and even getting close to the ASIS there. So this was the initial injury. This occurred, I believe, with a new hurdler. Literally, I think it was their second time going hurdling, and felt a pop and came in to see me with that. Typically, they're going to be point tender right at the iliac crest and right at the ASIS. I just have them do a straight leg raise. If there's any significant weakness and they're not able to do that against gravity, then your suspicion's high enough. You should just remove them from there. Let's get some x-rays and get the treatment started. This is what it looks like about 4 weeks out. So as you can see there, there's been some little bit of callus formation, a little bit of bridging, no displacement. So then that's when I start moving them through therapy at that time. So this is an interesting one. So this is a lesser trochanter avulsion. This was, I can't remember the exact mechanism, but came in with hip flexor pain right over the iliopsoas, and he had a pretty significant displacement of this fragment here. And so I talked to a bunch of surgeons, and everybody's like, I've never seen that before. I was like, I've never seen it before either. So what do we do with it? And so I asked half of them, they said, fix it. And I asked the other half, and they said, don't fix it. And so we went the non-operative route because his pain was controlled after a couple of weeks. So he came, that was 8 weeks post-injury. And I told him it's going to continue to heal down. And he came in a year later, and you can see where it migrated. It healed down. It's a little bit further superior, but completely healed down there. Not really having pain at the iliopsoas, little hip tightness. So overall went pretty well from that. AIIS avulsion. So this one I see most commonly. Again, this is going to be my track athletes and those type things. They're going to be sprinting, running, or they're going to feel a pop. This one, when you're palpating, instead of being at that iliac crest, you're going to go a little bit further down. And literally what you can do is have them do a straight leg raise. You can follow that rectus femoris tendon all the way up. And when you get to that insertion and you just push down, they're going to jump off the table. And once you get that, your suspicion should be high enough to just take them out at that point in time. And usually you'll see a pretty significant weakness from there. Again, what you can see on this left image here is very minimum displace, but you have your AIIS right there. That's the side of the rectus femoris attachment. And then 4 weeks later, when they came back in, you can see there's been ossification of that non-displaced fracture here. This one, I do tell the athletes and them that I'm very concerned and that we need to treat this appropriately. I had one time where the person tried to do stuff against my advice and kind of went a little more aggressive. The fragment displaced and actually went further down. And as you can see how close it is in relation to the acetabulum, they then started developing kind of almost pseudo-mechanical symptoms and had to be repaired surgically because it can fall down so close in that relation to the articulation of the labrum and the hip joint and the acetabulum. So ischial apophysitis is the one we see with our soccer players. Okay, so that are your kickers, repetitive actions, repetitive activities. They're going to be ones when you lay them prone. Their pain is usually most severe with full leg extension, resisted full leg extension. And then you will get to that gluteal fold, push right on the ischium. That's where we're going to jump at. This one wasn't a true avulsion. This is more of an apophysitis type presentation. But what you can see here is just the irregularity of the bone on this right side as compared to the left side. This is a little bit younger athlete, but no true evidence of avulsions and those type things. I'm currently pending seeing him again, see how he did. Management. This one's not as bad. It's only 8 weeks. So phase 1, week 1 through 4, my goal is to get pain resolution. I get them on crutches initially, and usually that's about 2 weeks. Once they are pain-free and they're able to walk in a pain-free motion, that's when I start transitioning to weight bearing as tolerated. I hold on PT at that time. I don't want to stress those structures too much. I want the bone to heal down because these are usually diarthroidal muscles, and we know like the hamstrings and other type things, you got to let them heal. If you go back too quickly, they're predisposed for injury. NSAIDs, Tylenol, and then, I address underlying nutritional deficiencies if they had a prior history of multiple avulsion, those type things. So we get to phase 2. That's when I start physical therapy. My goal is first get the restoration of strength and range of motion. Usually week 5 and 6, we're really focusing and hammering on range of motion, strength. I don't incorporate plyometrics at that time, no running, no sprinting. But then when I get into week 7 and 8, that's when I start getting those plyometrics in. I start aggressively moving them. And then by week 8, when I get them to clearance, they should be back to sprinting and running at that point in time. And then get them back into exos. There you go, Jacob. So management, overall treatment of apophyseal injury, stress reaction, avulsions is typically conservative. Surgical interventions typically only reserved for, your medial epicondyle avulsions and your baseball pitchers, your refractory pain despite conservative measures, rotational avulsion fractures, significant displacement, depending on the literature, can be anywhere from 2 centimeters to 3 centimeters, any focal neurological findings, or any symptomatic non-union or malunion injuries.